Good afternoon, everyone. We'll get started in one more minute. Okay, I'd like to welcome everyone to our very first monthly facility webinar. And our topic for today is long-term care top-cited deficiencies. You will hear from Heather Ackman as well as Jonathan Harwood. If you have any questions, please hold them till the end, and we have about 15 minutes towards the end that we can allow you to ask any questions that you like. Without further ado, Heather, you can go ahead and get started. You're on mute.
Good afternoon, everyone. Can you guys hear me better okay?
Yeah.
Perfect. I was double muted, so I apologize. Well, good afternoon, everyone. Thank you so much for joining us today. As you just mentioned, we are going to talk about the long-term care top-cited deficiencies. So the items that we'll be discussing today are going to be the top-cited deficiencies that I'm sure all of you have seen before and are aware of. So we just want to go into those top-cited ones and give some details into each of those. So next slide. The top-cited citations for the skilled nursing facilities. So these on this slide are the top 6 that we'll talk about today. To get some details into each of these. So we'll go ahead and get started and deep dive into each of these. Next slide, please. All right, the first one. So I'm sure all of you have seen this deficiency or looked through the SOM, the federal regulations, Appendix PP. So this one, free of accidents and hazard. So this is the top issued citation that is issued within skilled nursing facilities. The regulatory reference for this one is found at the Code of Federal Regulations at 483.25, or also at F689 in Appendix PP. So this specific regulation specifies that a facility must ensure that the residence environment remains as free of accident hazards as possible, and that each resident receives adequate supervision and or assistance to prevent accidents. So looking at this specific tag, let's go into a definition. So the first one I want to talk about is accident. So what does that mean? So for this specific incident, it refers to any unexpected or unintentional incident which results or may result in injury or illness to a resident. So this regulation further breaks it down and distinguishes between an avoidable and an unavoidable accident. So let's kind of talk about each of these. The first piece of that is avoidable. So an avoidable accident would be, an accident that occurred because the facility did not take measures such as the identifying environmental hazards or assess the individual risk of an accident. This could be evaluate and analyze the hazards and risks and eliminate them if possible, or identify and implement measures to reduce, such hazards. Implement interventions, including but not limited to supervision or even assistive devices. An additional within avoidable accident could be, monitor for the effectiveness of the interventions and then modify the plan of care as necessary. So those go under that specific avoidable accident. So the next one to touch on is the unavoidable accident. So this one, occurs despite the current facility systems and approaches. So this could be, identify The facility identifies environmental hazards and individual risks of an accident, evaluate and analyze the hazards and risks and eliminate them if possible, and if not, reduce them as much as possible. Implement interventions, including adequate supervision, consistent with the resident's needs, the goals, plan of care, current professional standards of practice. That's an important one. Monitor the effectiveness of the interventions and modify the interventions as necessary. So that unavoidable accident is that the accident occurred despite that current facility systems and approaches to, and those examples that I just discussed. So those are kind of breaking down, what the accident, kind of defining that, breaking down avoidable, unavoidable, giving kind of some details into that. A couple other things to think about with this one, could be some areas that frequently are seen, but of course are not limited to with this deficiency: resident smoking, resident-to-resident altercations, falls, wandering, elopement, also resident safety. So those are frequently seen with this deficiency. So to meet this regulatory requirement, your facility, we would expect your facility to identify and then evaluate those potential hazards and or risks associated with the resident, ensure that, individualized, person-centered interventions are implemented to, reduce those potential hazards and those risks, and then monitor to make sure that it's effective, the effectiveness of those interventions for those residents. So those are just some key areas with that deficiency. So let's go to the next one. So next slide, please. The next one, quality of care. So this one is the next top-cited deficiency within skilled nursing facilities. This one is Federal Regulation 483.25 or F684 in Appendix PT. So this quality of care, it applies to all treatment and care provided to a resident. So very broad. So all treatment and care provided to a resident. So the facility is responsible to ensure residents receive treatment and care that is in accordance with professional standards of practice. Also, another really key thing with this is comprehensive, person-centered care plans and resident choices. So very important with that. So when you're looking at that quality of care, looking at the big picture. So one key element within this requirement is that facilities must place a priority on identifying the resident's highest practicable physical, mental, and psychosocial well-being. So very, key things that go hand in hand with this. So this is defined, going back to what does this mean? So this is, defined as the highest possible level of functioning and well-being for that specific individual resident. So this can be determined through that comprehensive assessment that we spoke about earlier, by recognizing, addressing, physical, mental, psychosocial needs, the looking at, and planning, thinking about those items on a resident's care plan, the resident's plan of care, assuring that that resident's plan of care reflects that person-centered care. It includes the resident's, choices. What are their preferences? Goals. What are their concerns? Needs, required services to achieve that highest practicable level of well-being. So assuring that those are in there. Other things that, could be identified as non-compliant with this one, demonstrating that, a facility did not conduct an accurate and comprehensive assessment. So, I've mentioned this several times already. So assuring that is a comprehensive assessment, identifying that resident's specific needs and goals for care, and not just identifying them, but also implementing those measures. We want to ensure that those needs are met in accordance with professional standards. So very important. Just to give, just a couple examples with this, non-compliance, a frequent one, it could be end-of-life care. Non-compliance could be seen with a resident that's requiring end-of-life care, residents receiving, such as hospice services. So that could go under, this deficiency, that, tag of quality of care. So just, key things within here in the quality of care, very important. So individualized, looking at that physical, mental, psychosocial well-being, an individualized person. Next slide, please. Treatment services to prevent pressure ulcers. So of course, this is a very common thing that can be seen in long-term care, maybe, non-compliance, those type of things. And you can see this coincide with terminology. So, CMS, you'll see kind of in guidelines, it could be pressure ulcers, or you can see it be termed as pressure injuries, depending where in, it is written. So it does mean the same thing. So if you do see that in different areas. So this one is the next commonly cited or issued. This one is 483.25B or F686 in Appendix PP. So this one states that, based on, again, a comprehensive assessment, the facility must ensure that the resident receives care, again, consistent with professional standards, and ensure a resident does not develop a pressure ulcer unless clinical condition demonstrates that it's unavoidable and that a resident with current pressure ulcers receives treatment and services to promote healing and prevent new ulcers from developing. So lots of different terminology and wording all within that regulation. So, meeting each of those within that regulation. So unavoidable. So you have to demonstrate that you are ensuring that resident does not develop those pressure ulcers unless clinical condition demonstrates that it is unavoidable. So you have to meet all of those. So it's very key that you read through all of that. So the overall intent, looking at this one, is the resident does not develop a pressure ulcer, unless it's just absolutely clinically unavoidable and that the care is provided in accordance with the professional standards. So we want to ensure if they have, an existing pressure ulcer, that we're ensuring healing of that pressure ulcer. We're preventing additional pressure ulcers from developing. Other key things with this one would be, looking at avoidable and unavoidable. We kind of mentioned that on a previous one, so this kind of goes hand in hand. So looking at avoidable, means that the resident developed a pressure injury, or pressure ulcer, and that the facility did not take one or more of the following actions to avoid that injury. So, evaluating the clinical condition and risk factors, define and implement interventions that, are consistent with that specific resident needs, the resident goals, their professional standards, did they, monitor and evaluate, or did they revise the interventions if necessary? So those are big things, avoidable, looking at those specific areas. Looking at unavoidable. So this is when, the resident develops a pressure injury, even though the facility evaluated, correctly. They evaluated the resident's clinical condition, evaluated, the risk factors. They defined and implemented the correct, interventions that are consistent with their needs, their goals, their professional standards. And, they monitored, they evaluated, and if applicable, they revised their interventions. So they did all, they met each and every one of those. So those are the big differences between that avoidable and unavoidable. So I want to touch on those with that specific one. Specific items to think about with pressure ulcers and injuries. Of course, documentation is key, but also risk factors. Things to that are key with this. Mobility, functional ability, like comorbid conditions, drugs. Are they on medications that can impact healing? Other medical conditions that can impact blood flow or even circulation. Do they have any cognitive impairments? Do they have, incontinence, nutrition, hydration status issues? So those are things to think about with this one also. Next slide, please. Our next one, so the next top cited deficiency, infection control and prevention. So this one is found under CFR. It is the 483.80 or the F880, and this is in Appendix PP. So this regulation directs facilities to establish an infection, prevention and control program. That includes a system for preventing, identifying, reporting, investigating, and controlling infections and communicable disease, not only for residents, but also staff, volunteers, visitors, or other individuals that are providing services within the facility. So this system should be based on the facility assessment and in accordance with nationally accepted standards. So this one, should contain, or the facility specific infection control program should contain written standards, with policies and procedures for the program. It should include a system, and state a system of surveillance. When, whom, who's going to report the incident of communicable diseases, standard, and transmission-based precautions, isolation methods, including, what type, the duration of isolation, and ensuring the least restrictive isolation method, circumstances addressing employees with communicable diseases, and their contact with residents, and also hand hygiene procedures to be followed. So those key areas need to be in those, policies and procedures. All of those key areas need to be included. So it needs to be individualized, have each of those areas completed. So this program should also, encompass a system for, recording incidents, under, corrective actions, a system to address facilities, such as linen, handling, storing, processing, that should be included. The program also should have an annual review. So it should be reviewed annually and documented. If any changes, are needed, it should be reviewed and changes are made as needed. Some other common areas, concerns or other things that are identified under this one, could be, possibly a facility failure of an effective surveillance system in place. A good example or a frequent one that we might see is a facility did not investigate, document surveillance of an outbreak. It could be a GI illness. I know, COVID, that is, a common thing, and it was very large. So let's talk about something different. Let's talk about a GI illness. So, that could be something that maybe a facility did not investigate. They didn't document the surveillance of an outbreak of a GI illness. So, this resulted in, improper isolation. And then that coupled with improper hand hygiene practices, which then led to and resulted in continuous spread of the GI illness throughout the facility. So, breaking that up. So moving from respiratory, not thinking of COVID, it could be something else. So such as a GI illness. So that would go hand in hand, just to give an example of that. So really important key things also is don't forget the differences between the different precautions. So there's standard precautions, contact precautions, droplet, airborne, and the appropriate times to implement those precautions. So that's really important. The other items to think of with infection control, I talked about making sure that your infection control plan is reviewed and update annually, but also don't forget about making sure that it's in alignment with the facility assessment and any current MDROs. So those all need to be in alignment together and then reviewed. Next slide, please. ADL, so activities of daily living for dependent residents. So this is our next one. This one is, or can be found in CFR 483.24, A2, or F677 in Appendix PP. So this regulation is, specific to dependent residents, that they shall receive services to ensure good nutrition, grooming, and personal and oral hygiene, and that a diagnosis alone should not justify the decline in a resident's ability to perform ADLs. So that's important. Not just a diagnosis alone should justify that decline, unless it is determined to be unavoidable decline. A resident should still participate in as much as they can or desire to participate in. So some factors, that may be an unavoidable decline, but are not limited to, so just, a couple examples. It could be, a natural progression of a debilitating disease, resulting in a functional decline of that resident. A acute episode, an illness, disease resulting in mental instability or physical instability. That could be another example. The resident or resident representative decision to refuse care. That's real important that should be documented to reflect that refusal of care and education provided and interventions in place to minimize a decline in functional ability. So it's important to, assess needs and goals and preferences, and this should be, periodically reviewed and revised as appropriate. So that's the ADLs for dependent residents. So our next one, next slide, please. Thank you. Our next one is free from abuse and neglect. So this one is our next top-cited deficiency on the skilled care. This one can be found in the CFR, Part 482.12, and then the State Operations Manual, starting at F600 in Appendix PP. So this specific regulation, states that the resident has the right to be free from abuse, neglect, misappropriation of property, and exploitation. So this one's very specific, but it can, we cite this very frequently, and it can be seen in many different ways and for many different facilities. So in addition to this, the resident must be free from any verbal, any sexual, any mental, physical abuse, corporal punishment, involuntary seclusion also falls under this. So just a few key factors when you're thinking about this specific regulation. in the guidelines regarding abuse and neglect. So I kind of want to break down just a few definitions specifically to this one. So the first one is abuse. What does that mean? So abuse can be defined as the willful infliction of injury, unreasonable confinement, intimidation, or punishment with resulting physical harm, pain, or mental anguish. This also includes the deprivation by an individual, including a caretaker of goods or services that are necessary to attain or maintain physical, mental, and psychosocial well-being. So that is just defining abuse. Next is neglect. So this is defined as a failure of the facility, its employees, or service providers to provide goods, services to a resident that are necessary to avoid physical harm, pain, mental anguish, or emotional distress. The next is willful. This is defined as in 483.5, the definition of abuse, and means the individual must have acted deliberately, not that the individual must have intended to inflict injury or harm. So abuse can occur, in several different situations. So just a few examples that we see frequently. So abuse could include, could occur between an employee and a resident, employee to resident. It could occur from resident to resident, resident to visitor, visitor to resident. So it's important for the facility to conduct a thorough investigation if the situation or occurrence meets that definition of abuse. So that's very important to conduct a thorough investigation. So some characteristics or attributes, behaviors by family members that can increase risk for abuse. These could include, but are not limited to, could be unsympathetic or negative attitudes towards residents, could be facility policies geared toward the interest of the establishment rather than the residents, inadequate training or preparation for caregivers, poor administration oversight, staff burnout, or stressful working conditions, the physical plant issues or problems. So there can be many, many different characteristics, behaviors, things that can just increase that risk for abuse. So just things to think about in that sense. So other risk factors that can predispose a resident to abuse, predispose a resident to abusing others or being abused. It could be verbal or physical aggressive behavior, wandering, you're seeing sexually aggressive behavior, possibly inappropriate sexual remarks, taking or touching other residents' items. So just things to think about to help prevent, seeing those behaviors to try to prevent things from happening. Other things with resident to resident altercation, should be reviewed as potential situations of abuse. So you have to review that to determine if that definition of abuse is met. So it should not just automatically be ruled out. It needs to be, reviewed, investigated, looking at, cognitive impairments, mental disorders, but it should be investigated. Sexual abuse is another type of deficiency investigated with this regulation. So looking at, unwanted intimate touching of any kind, sexual assault, battery such as rape, forced observation of, pornography, explicit photographs, anything like that would be included in this deficiency. Regardless, one thing to add on this one as I end, regardless of the circumstance or situation with this one, So the regulatory guidelines, as well as the Social Security Act, direct that each resident has the right to be free from abuse. I know we always go to that regulatory guideline, but also the Social Security Act. So next slide, please. All right, I would like to turn it over to Jonathan. He will be completing the rest of our presentation, and he will be speaking about the IID and ICF. Thank you so much, everyone.
All right. Well, thank you, Heather. I appreciate that. My name is Jonathan Harwood. I am the Division Chief for Long-Term Care Field Operations. And as Heather stated, she just went over the skilled nursing long-term care top-cited deficiencies. So next, I will be discussing the most frequently issued citations within our ICF and IID facilities. So listed here is just an overview of those top-cited citations. We will review each of those in more detail in the next few slides. But as you can see, the categories include governing body, client protections, healthcare services, active treatment, and facility staffing. Next slide, please. All right. Okay, so the first one regarding governing bodies. So the governing body and management category is the top cited deficiency within the ICF-IID facilities. And the information regarding the governing body can be found at Code of Federal Regulation Part 483.410. And the associated condition of participation is W102. And that is found at Appendix J in the State Operations Manual. Within the governing body and management condition, the most frequently cited area is W104. And W104 states that the governing body must exercise general policy, budget, operating direction over the facility. Specifically, the governing body must develop and monitor policies, procedures, revise those policies and procedures as necessary to ensure that the facility can effectively operate, ensure that there's necessary staffing, training, equipment, environment, and the environment is suitable for the staff to provide care and active treatment to the clients. The governing body is typically cited when the facility has failed to address a particular situation, whether it be through a policy or a procedure, and has failed to ensure adequate administration and operations of the facility. There's also concerns that the facility lacks a process or procedure to address those general operations within the facility to ensure that those clients' needs are met. So while W104 is the top issued citation within this condition, we also see W120 and W111 frequently cited as well. W120 states that the facility must assure that outside services meet the needs of each client, and that the facility coordinates programs, services to meet the needs of clients that they serve. So this could include services within the facility, but also outside services such as hospital visits, physician visits, dental visits, or any type of day programming as well. And then lastly, W111 refers to the client's records. This does direct that facilities have client records that document the client's healthcare, their active treatment, social information, and then this also directs that the facility ensures the protection of the client's rights as well. The content within the client's records should be an accurate representation of their experience within the home. And so we often see issues or concerns or noncompliance related to either incomplete information or inaccurate information documented within the client's records. Next slide, please. The next top cited area is in regards to client protections. And this can be found at Code of Federal Regulation Part 483.420. And the associated condition is W122, protection of the client's rights. W122 does direct that the facility ensure the rights of all clients are maintained. They must ensure that the rights are maintained even when the clients are not fully competent. And they should engage in programs or activities that ensure the protection of the client's rights and advocate for the individual. The top cited deficiency within this condition is W154, which states that facilities need to have evidence that all alleged violations of abuse, neglect, or mistreatment are thoroughly investigated. This could include, but is not limited to, a collection of interviews by all parties involved or potential witnesses, statements, any physical evidence, any applicable maps or pictures, diagrams, a review and analysis of the information related to the allegations, any resolution of discrepancies, and then a summary of conclusions and a recommendation for any action or corrective action needed to ensure that the clients are safe during and after that investigation. The next top cited deficiency within this area is W149, which is regarding written policies and procedures prohibiting the mistreatment, abuse, neglect of clients. Specifically, the facility must develop and implement written policies and procedures that would prohibit the mistreatment, neglect, or abuse of their clients. The facility must ensure that there is a system in place that screens and trains employees. And there's also a system to protect clients and prevent, identify, and investigate and report any form of abuse to the facility's administration. So some of our common issues surrounding noncompliance within this area include, having policies or procedures, or rather not having policies or procedures that address abuse, neglect, or mistreatment of clients, or not fully implementing those policies or procedures. The third top cited deficiency within this condition is W153. This states that the facility must ensure all allegations of mistreatment, abuse, or neglect and injuries of unknown origin are reported immediately to the administrator or other officials in accordance with the state law. So some of our issues concerning noncompliance within that section just involve the underreporting of potential abuse, neglect, mistreatment, or any injuries. Next slide, please. Okay, so the next area that is frequently cited within our ICFI ID homes is in regards to healthcare services. And this information can be found at CFR 483.460, with the condition being W318. This regulatory requirement encompasses that healthcare services are provided to the client. The most frequently issued citation within this condition is W331, and this directs that the facility provide clients with nursing services in accordance with their identified needs. This also directs that the nurse should respond to clients' needs or concerns, perform assessments as applicable, formulate appropriate interventions, communicate with the physician, and administer any treatment as ordered, and also requires that the nurse or healthcare provider evaluate the interventions. So one of our common areas of noncompliance is in regards to nursing assessments post-injury, whether it be lack of assessment or lack of follow-up interventions, or lack of communication to the physician following a significant or abnormal event. The next commonly issued citation within this condition is W322. So this regulation directs facilities provide or obtain preventative and general care. Specifically, the facility should have a procedure to ensure clients receive general health care to achieve optimal levels of wellness. So the facility should have written agreements in place specifying responsibility of the facility and that of the outside provider if the facility is unable to provide a particular service. An example would be having an agreement with an outside lab testing or radiology services if the home was not able to provide those services themselves. There should also be a component including preventative healthcare services such as screening for certain healthcare diseases. Another common citation within this condition would be W369, and W369 states that all pharmaceuticals, including those that are either self-administered or administered by a staff member, are administered without error. So some of our common areas surrounding noncompliance are when we see that those medications are administered in error or administered not according to the prescribed dosage or physician order. Next slide, please. The next top cited deficiency for the ICF-IAD program is in regard to active treatment, and this information can be found at Code of Federal Regulation 483.440 with the associated condition at W195. This states that each client must receive an active treatment program. The most frequently issued deficiency within this condition is W252, and this regulation refers to the criteria in the client's individual program plan. And that individual program plan criteria and objectives should be documented in measurable terms. The criteria should be evaluated to reflect the client's progress. So some of our issues or concerns that we typically see noncompliance with are when interventions, treatments, or interactions are performed but not necessarily reflected in that individualized program plan. We may also see concerns if revisions are not being made to the new active treatment plan when they are needed or identified, or even being implemented in practice, but not necessarily reflecting on that individualized program plan. Another common cited deficiency within this area would be W263. This regulation directs that homes should ensure that the individualized program plan are conducted with written informed consent. So this could be consent obtained from the client, from parents if the individual is a minor, or from a legal guardian. And there are certain components required within the consent. The consent must be in writing specific to the individual program. Any restrictive practice should be in there. The consent should contain a time frame, and the individual providing the consent should be aware of the specific treatment, the reason for treatment, risks versus benefits, any alternatives, and their right to refuse as well. So we typically see compliance issues with either failure to obtain the consent or not including all components within the informed consent. Next slide, please. So the last top cited deficiency within the ICF-IAD homes is in regards to facility staffing. And this can be found at CFR 483.430, and the condition of participation is W158. This condition directs the facilities to have qualified staff with required trainings. So the top issued citation within this condition is W189. And this regulation states that each employee must be provided with initial and continuing training that enables them to perform their job duties effectively, efficiently, and competently. So there should be some type of orientation program that supports newly hired individuals, provides them with the necessary training, for their job duties. And then for any individual that's working directly with clients, that training should focus on skills and competency, which will help benefit the clients. So care that is directed towards the clients. We typically see compliance issues with staff not being provided either their initial or continuing training for them to be able to efficiently carry out their job duties and tasks, which could ultimately result in negative impact to the client as well. The next top issued citation within this condition is W159, and this directs that the active treatment program must be integrated, coordinated, and monitored by a qualified intellectual disability professional, or a QIDP. And the criteria for the QIDP can be found at CFR 483.430, subset A, 1, and A2. The QIDP should ensure that all aspects of the active treatment plan and program, including the creation of the individualized program plan, meet the individual's needs. Should also coordinate any internal, external program services to facilitate the acquisition of client skills and behaviors, and then promote competent interactions of staff with clients in those programs. So some compliance-related issues within this requirement are surrounding, whether the QIDP is monitoring the active treatment program or lack of updating, revising those goals of the active treatment program. Next slide, please. Okay, so that concludes our presentation for our top cited deficiencies within our long-term care homes and our ICF IID homes. So at this time, we do have some time for some questions.
Okay, we do have some. Christine, did you want to handle this, or you want me to go ahead and handle it?
Go ahead, Camille, that's fine. Thanks.
Okay. We do have some questions in the chat. If you do have questions, you can put it in the chat. It's my understanding that you can't come off of mute right now. So the first question that we have is that someone was informed by a surveyor that willful or intent is no longer applicable to abuse when they are investigating. Can someone take that question?
Yeah, I can answer that. The State Operations Manual does define willful, and I cannot specify what the actual definition is, but it does state that does not have to be intent to cause harm, but that the individual acted in a willful manner, I believe, is the wording of that.
Okay, the next question is, if suspicion of abuse that did not result in injury or mental anguish, if the resident stated he or she is okay and forget about it, is it still considered reportable?
If it meets that definition where where it was willful, then it would be considered a federal reporting requirement.
Okay, are there any other questions at this time? All right, if there are no other questions, that will end our, okay. If there are no other questions, that will end our meeting today. Thank you. Have a good day.
Thank you, everybody. Have a good day.